It's von Hippel-Lindau syndrome. So they've got retinal angiomas, which has resulted in bleeding, which has resulted in a prosthetic eye. And then the patient has got multiple cerebellar hemangioblastomas. There's a craniotomy also. Von Hippel-Lindau, autosomal dominant. One of the things that you need to say in the exam, whether it be in the long cases or in the viva, is to screen the family because these patients have an autosomal dominant inheritance. Okay, this is quite a tricky one. I'm not sure whether you can see it very well, but if I told you that these are multiple small miliary and slightly bigger than miliary metastases, what's going on there? Yeah, thyroid, got surgical clips. I'll just show you that. Hopefully you can see those surgical clips now. Thyroid metastases. Okay, and this is a patient who's got thyroid acropathy. So we've got very similar to HPOA in many ways, but this is due to thyroid acropathy. Okay, it looks very similar. I think it's fairly indistinguishable from HPOA or HOA in patients who've got clubbing due to pulmonary disease. Just to remind you, Hexarad are making this free for you tonight. Okay, this is a male patient, and we've got a very deformed femur, which has been fractured and remodeled, and we've got this massive soft tissue swelling. What do you think this might be? Yeah, it's a hemophiliac pseudotumor. So here's the MRI, and you can see on this heavily gradient echo sequence, we've got low signal, which is the hemosiderin in the pseudotumor, which is deforming the periosteum of the femur. Hemophiliac pseudotumor. Okay. So it's a male patient, and we've got spikes of new bone formation, which is very typical of hemophilia. So these spikes here. Okay, tell me what's going on here. This is a child. They've got a neckline in situ. It's tunneled, and there's two lumens. There's no fractured lead. Have a look at this thing here. Have a look at this thing here. This thing here. So these are sarcoma metastases. Okay, sarcoma metastases. They could be metastases from anything really, but most likely in a child is sarcoma. And of course, sarcoma metastases can predispose to pneumothorax. So there's the nodule, the biggest of the nodules there, but there's one there, there's one there. The more you look, the more you can see. Okay, tell me what the pathology is here. Yeah, it's meningioma. See the dural tail, broad-based, extradural, extramedullary. and this is pressing on the cord. So this is a meningioma. Here it is here. And it's pressing on the cord. Okay, CT scan. We've got a well-defined low attenuation structure, which is molding to the surrounding structures, and it's coming from the middle mediastinum. Bronchogenic cyst, absolutely bronchogenic cyst. Yeah, well done. Okay, this is a 15-year-old boy who is run over by a bus, and he's got a fracture of the clavicle. He's also got a left apical pleural cap, and he's got widening of the mediastinum. So this indicates that he's almost certainly got a severe aortic injury. Okay, contusion over here, and he's probably had a transection of the aorta. There's the parietal pleura. This is extrapleural hemorrhage. It's shifting the trachea over to the right, and this patient died before they can get into the scanner. Okay, so aortic transection. Okay, this is pretty straightforward. Whenever you see pectus excavatum, okay, there's the sternum here. You don't want to do a lateral view when you've got a view like this. And what happens is the posterior ribs are like that. So there's an exaggerated anterior obliquity and the horizontal posterior ribs, okay? But this patient, as well as having a pectus excavatum, which we should always diagnose clinically, they've also got Pancoast tumor. So in the exam, don't ever look at something and then just say to the examiner, well, it's this. Keep on looking at the film. Make sure that you don't miss something that is very important. And this patient had a Pancoast tumor, which you can actually see on the lateral. Okay, what is the cause of this patient's recurrent chest infections? Yeah, achalasia. So this is achalasia. Let's see, there's gas in the esophagus. There's possibly a fluid level here, I'm not really sure, but there's certainly fluid down here, which is causing a double right heart border, and you've got gas in the dilated esophagus. Okay, so there's the right heart border, and there's the dilated esophagus. And always address the clinical question that was posed by the examiner. The examiner wants to know, is there anything responsible for the patient's recurrent chest infections? Now, it is the achalasia, but there's no actual aspiration pneumonia on that film. Pulmonary fibrosis without honeycombing. Calcified left ventricular aneurysm and a dense liver. Put it all together. Amiodarone. So amiodarone contains iodine. It's metabolized by the liver, and so the liver becomes dense, and it causes pulmonary fibrosis. Not in everyone, but in some susceptible individuals. So this is a typical amiodarone lung case. This patient comes in with a coma. GCS is 3. After having been higher than that, yeah, there's a thrombosis in the basilar artery. And can you see that there is low attenuation change here and here? And as we go further up, we've got low attenuation change here, here. Low attenuation change. and we've got an occipital infarct, which is fresh. We've got bilateral thalamic infarction, which is fresh. And we've got an old occipital infarction. So this patient has a basilar artery thrombosis with infarction. So they are probably not a good candidate for thrombectomy. However, you may still want to discuss it with the interventional neuroradiologist or the neurologist just to make sure that the thrombectomy wouldn't be appropriate to try and prevent further infarction. Okay, so it's always worth having that discussion. And there's an infarct in the posterior circulation. So somebody's asked me, why not a good candidate? Well, you're going to put the patient through a potentially hazardous procedure when they've already got severe infarction. Okay, so that will be a discussion between yourselves and the neurologist and the interventional neuroradiologist. The sagittal section shows a very nice thrombus in the basilar artery. Okay, this is a close-up of a Swan-Ganz catheter. We don't use them anymore. And this is where a balloon was deployed in the pulmonary artery to measure the wedge, pulmonary artery wedge pressure. And this is an old-fashioned Swan-Ganz catheter. But you can see that the patient has got ARDS and a pneumomediastinum. This is brought to you by Radiology Masters and Hexarad. Now, venous sinus thrombosis. If you have a patient who's got a venous sinus thrombosis and you give contrast, whether that's on CT or on MR, you're going to get what's called the delta sign. Okay, so this is the delta sign. And this is with contrast. Okay. And if you don't give contrast on CT, you're going to get increased density in the superior sagittal sinus, and that's called a cord sign. Now, when you've got venous sinus thrombosis, you may also get venous infarction, which is characterized by its non-arterial distribution and the fact that you can get a hemorrhage. So it's a nice demonstration of hemorrhage. So that's with contrast. This is without. And this is the typical appearance of very advanced complications of venous sinus thrombosis. Another complication of venous sinus thrombosis can be a subarachnoid hemorrhage. Okay, so either a venous infarction with hemorrhage or subarachnoid hemorrhage. Now, this is the delta sign, and you only see it with contrast. Okay, the pseudo delta sign is due to a subdural hemorrhage, where you get hemorrhage either side of the superior sagittal sinus, and that's the pseudo delta sign, and that's with no contrast, but it's a different pathology. So this is central venous sinus thrombosis. And if you look at a different patient, unenhanced, there is the transverse sinus full of thrombus. When you do the CT venogram, you've got no contrast in the superior sagittal sinus. And we've got patchy uptake in the vertex portion of the superior sagittal sinus. And we've got an absence of uptake of contrast where we saw the thrombus on the unenhanced. That's CT minus, and that's CT plus. Okay. So dense and then not so dense. And that's not because it's not dense, it's just that the contrast enhanced veins are denser than the thrombus. If you did an MRI scan in this patient or any other patient with an acute thrombus, you'll see two things. On the T1, you'll see increased signal where you've got thrombus, this time in the superior sagittal sinus. And on the T2 weighted image, you've got a loss of the signal void and increased signal in that superior sagittal sinus. Okay. Doesn't show very well, but if I told you that this is a mediastinal mass which is well defined above and below the clavicle, it makes it either middle or posterior in position. The patient is suffering from dysphagia. Have a look at those CT images and tell me what you think is going on. Well, we've got a vessel here, got a vessel there, got a vessel there, got a vessel there, rim calcification, it's aneurysmal, and it's going behind the esophagus, which is here. So if I draw the esophagus as yellow, this structure, which is arterial, is going behind the esophagus. And it's aneurysmal, and it's arising from the diverticulum of Komarov. So this is aneurysm of an aberrant right subclavian artery. Okay. And it's called dysphagia lusoria. So lusoria is spelt like this. Dysphagia lusoria, which just means unusual, funny dysphagia. Okay, what do you think about that eggshell calcification of the lymph nodes? It's not eggshell calcification of lymph nodes. This is the aorta, and this is the pulmonary artery. So we've got very prominent pulmonary arteries. There's the small aorta, and this is pulmonary arterial calcification, secondary to long-standing pulmonary artery hypertension. And because they branch, they are blood vessels and not lymph nodes. Okay. Now, something that would give you long-standing pulmonary artery hypertension is like a VSD or an ASD. And when you get shunt reversal, that indicates that you've got very marked pulmonary artery hypertension. That's called Eisenmenger's syndrome. Now, we tend not to see this very often anymore, and that's because these patients are sorted out earlier on in life. Okay, so back in the day, these patients were not quite so lucky, and this was picked up quite late. But nowadays, it wouldn't get to this stage. So Eisenmenger's syndrome. Just take away the ink. There you go. Right. Crescent sign. And whatever was going on here was also going on in the left lung, and that produced a pneumothorax. There's Chilaiditi syndrome. We've got bilateral aspergillometer. Okay. So the crescent sign. So there's the in the cavity, there's the fungus ball, aspergillometer, and they can sometimes be associated with pneumothorax, or in this case, a hydropneumothorax. Okay, well defined above and below the clavicle means that it can't be an anterior mediastinal mass. And if it can't be a mediastinal mass, what must it be? Well, it must be in the middle or posterior mediastinum. And if it's in the middle or posterior mediastinum, it's probably a bronchogenic cyst or a schwannoma. Okay. And in this particular case, it was a cyst which was uniformly well defined on the T1 weighted images and moderately high signal due to the presence of protein, and moderately high signal due to the presence of, high attenuation due to the presence of protein on CT. And this was a bronchogenic cyst. If a bronchogenic cyst has got gas in it, what's happened? Yeah, they've got infection. This is a Brazilian patient. Tell me more. Yeah, it's Chagas disease, South American trypanosomiasis. Very, very dilated esophagus, and it's got food in. It's so dilated, it's actually now obscuring the right heart border. And don't forget, something that is really, really massive might start disobeying the rules of which anterior or middle compartment the actual esophagus is in. So a really, really big, distended, dilated esophagus might actually encroach onto the anterior mediastinum. What's wrong with that patient? Absent clavicles, yeah, cleidocranial dysostosis. Don't forget it's associated with Wormian bones, supernumerary teeth, and a persistent anterior fontanelle. Carcinoma of the bronchus. What's the cause? Cigarette lighter. Cigarettes, left lapel pocket. Nothing to see on that slice. Different patient who's got a head and neck tumor with jugulodigastric lymph node enlargement. They've got cigarettes in the top left-hand pocket. Okay, tell me what's wrong with that patient. Close up. No, it's not. These are vascular shadows. Yeah, it's rib notching. You can't really see the aortic knuckle terribly well, so it's an attenuated aortic knuckle. This is rib notching due to coarctation. Another example of rib notching here, 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 here. And this patient has got coarctation. There's some more rib notching up here and here. This patient has got rib notching, but it's just involving one rib. And they've also, oops, let me just delete that. That was from the previous one. They've got rib notching just there, and they've got a neurofibroma just there and just here. So this patient's got neurofibromatosis, and scalloping of one rib. This patient has got multiple rib notching, and this is due to neurofibromatosis, not coarctation, because you can actually see the schwannomas at the periphery of the film, giving you the incomplete border sign. Okay, so very important to have a look at the periphery of the film. So if I go back to that coarctation case, the periphery of the film, you can't see any schwannomas, but this patient, you can see schwannomas on the periphery. So I've just drawn a diagram there. Now, that's called in profile. This is called en face. So if I had a big nose, you would never make the diagnosis en face. You'd make the diagnosis in profile. And in the same way, you're going to make the diagnosis in profile. We've got the incomplete border sign, and they are going to become apparent at the periphery. Another example of neurofibromatosis, schwannoma, and we've got rib and ribs or dysplastic ribs. Scoliosis, and the scoliosis, there's a bit of scalloping here, and we've got neurofibromatosis on the skin. So this patient's got neurofibromatosis. Patient's got an abdominal CT scan. Don't forget, look at the skin. Have they got neurofibromatosis? What else could you see in such a patient? You might be looking for an adrenal mass, such as pheochromocytoma. I got this from the New England Journal of Medicine, and it's a patient who has got bilateral renal transplants which have rejected, and they've also had renal osteodystrophy. Okay, so they've got renal bone disease. Rugged Jersey spine. This is from the European Journal of Radiology, and very nicely shows the rugged Jersey spine. For those of you who don't know what a rugged Jersey is, it's a jersey that is hooped like this. Not everyone who plays rugby wears a hooped jersey, but that's how it was originally described. So there's the density. Excuse me. There's the lucency. It's not actually lucent; it's normal bone. Okay, so what's going on here? We've got dilated colon, we've got thumbprinting, and we've got pseudopolyposis. Now, how do we get pseudopolyposis? Well, pseudopolyposis, there's a normal bowel. We get inflammatory change in the mucosa. The mucosa sloughs off, giving you bloody diarrhea. And the remaining mucosa becomes edematous, and it looks like a polyp, but actually is a pseudopolyp. So we've got pseudopolyposis, and this is a feature of ulcerative colitis with toxic megacolon. And that's why we get the pseudopolyposis effect. Okay, double bubble, what's the diagnosis here? Yeah, duodenal atresia, double bubble, and we've got a vertebral anomaly here. And these can be seen in patients with Down syndrome or the infants of diabetic mothers. Okay, so duodenal atresia, and you've always got to look for renal, rectal, and vertebral anomalies. Okay, with these gastrointestinal problems. Okay, we've got a child, deciduous teeth, and we've got multiple lytic lesions in the skull vault. Yeah, lytic, eosinophilic granuloma, or LCH. Okay, this patient is complaining of a sore mouth. Any thoughts? There's the coronoid process on the left, and the coronoid process on the right has been eaten away because there's a malignancy. Okay, so the malignancy is very evident over there. So we've got an absence of the coronoid process of the mandible, so the bone has been eaten away, and this was due to a renal cell cancer. Okay, and this one, what's going on with this OPG? Well, we've got a subcondylar fracture of the mandibular ramus. Okay, tell me what's going on here. This is not LCH. LCH tends to be upper zone rather than lower zone, and this is kind of everywhere. This is a patient who's got pneumothoraces, and this is end stage pneumocystis carinii pneumonia. Okay, pneumocystis carinii pneumonia, and we've got surgical emphysema, we've got pneumothorax, intercostal drain, and multiple pulmonary cysts. Okay, look at the right hilum. It should be lower than the left hilum. Okay, so it should be down here, but it's actually higher and it's been pulled up, and we've got hypertransradiancy, and that's because we've got a very tight right upper lobe collapse. So it's a right upper lobe collapse. There it is. And it's pulling the right hilum upwards, and the right upper lobe is going towards the anterior chest wall and towards the mediastinum. Okay, this patient has dilated small bowel. Could be small bowel obstruction, could be paralytic ileus, could be ischemia, and ischemia is the one that we always forget. So don't ever forget ischemia. So we've got dilated small bowel loops. What are you going to do next? Well, you're going to do a CT scan. And the CT scan is primarily designed to exclude or confirm mechanical obstruction. And here we go. Got lung metastases, liver metastases, dilated small bowel, hydronephrosis of the left kidney, stones in the left kidney lower pole, retroperitoneal lymphadenopathy. And just here, we've got a tumor in the small bowel. And there's the tumor just there in the small bowel. So this is a mechanical small bowel obstruction due to a space-occupying lesion. It could either be a lymphoma, but because of the liver and the lung involvement, it's more likely to be an adenocarcinoma. And in fact, that's what it was. The other thing it could be is a metastasis from a breast cancer, maybe, or even from a Krukenberg tumor, such as a gastric carcinoma. Okay, another small bowel dilatation. What's this? What's that thing there? An ear stud, possibly. What else could it be? Could be a capsule. And if we look at this particular patient's CT, small bowel dilatation, small amount of free fluid in the abdomen. And you can see that we've got inflammatory bowel disease, Crohn's of the small bowel, bit of fluid there. And then there's the capsule. Let's just go back. There's the capsule just there, which is lodged at the site of the stricture and is exacerbating the small bowel obstruction. There's the inflammatory wall of the small bowel. Small amount of ascites in the pelvis. There's the uterus. And this is capsule endoscopy, resulting in worsening of the small bowel obstruction, just there. Okay, I hope you found that useful. I'm going to finish there. And what I am going to do, I'm going to do something next week. Sometime. Just to remind you, this was brought with a combination of Hexarad and red velvet custards. Thanks for your attention.
Here comes the flood again. Watch it fall from the sky. Feel it soak through my flesh and my blood. Feel it burn in my eyes. When I say how much more can I take, I know the water's rising up. Watch the waves crest and break, and though I made nothing but a sound, I fear that I may drown. I fear that I may drown. still I cursed your name. I cursed your name. So now the end, what I've been running from. Though I've tried, I cannot lift my head. Oh, what have I become? When I say how much more can I take? I know my time is running short. I am broken and I'm breaking, though I've worn myself so thin. Coming home again. And though I do not know my heart, well, I know myself down to my bones. But if my bones should come apart, then I'll have nothing left to give. But if you take me in, coming home again. And if you take me in, coming home again.
Did you ever read Albert Camus? The bit about how you gotta turn away from the world to understand it. Did you feel this too? I was in a mindless kind of queue, and then I went and pulled myself right out. Found things just got a bit wilder. Haven't you heard right? It's a truly sad life. Tomorrow you could be a big hole, and the next day you could be a king. Can't return to my old ways when the nothingness held up the day. And now come to think of it, I only got out of bed for you. I used to think nothing of the end. Beating each day was my forte, spinning out time like a spider with a web, devouring every second I was fed. But then I went and sailed right out, got lost, found things just got a bit lighter. Haven't you had love? It's a truly absurd love. Tomorrow you could be a big kiss, and the next day you could be a stone. Can't return to my old life, quite oblivious to all of the signs. And now come to think of it, I only got out of bed for. Invited to the feast, only had one grape. Always arrived ahead of time, but turned out I was late. I can see now the world does not care, and that's okay with me. So I never really needed a boat to sail out to the sea. Haven't you heard right? It's a truly absurd life. Tomorrow you could be a big hole, and the next day you could be a king. Can't return to my old ways when and the nothingness held up the days. And now come to think of it, I only got out of bed for you. Having you had love is a truly sad love. Tomorrow you could be a big kiss, and the next day you could be a star. Can't return to my old life, quite a